Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Alan Feren, otolaryngologist and patient advocate. Today's Kevin MD article is How to Handle Medical Gaslighting. Alan, welcome back to the show.
Thanks, Kevin.
All right, so tell us what this latest article is about.
When I started to get interested in gaslighting, I had no idea that I was going to end up writing a trilogy. At first, I had read a couple of articles that were in mainstream newspapers, and gaslighting really is a very emotional type topic. It has the tendency to place blame on physicians, and obviously, as a physician, I take issue with anything that involves my profession. So the first articles that I read explained what it was, and I decided that it was important to reframe it. So the first article was really about what gaslighting was, how to recognize it if you've been gaslighted. And as I finished that article, I realized that I needed to have an article that's more balanced from both the patient perspective and the physician's perspective. And so that was the second article that I wrote, which explained why gaslighting occurs and reframed it really not as intent, but as impact, and explained the reasons why it happens, which are, as we know, we've got patients who are anxious, come into the office unprepared, they have a big story to tell, they're not organized in their storytelling, physicians who are on a treadmill, a great deal of pressure to have throughput, they're on that treadmill, their administrative overload, heavy documentation requirements, and this has all led to a collision of events that result in patients feeling dismissed, disregarded, and patients leave an office feeling worse than when they entered, not because of the diagnosis, but because they feel that they lost their voice, there was no agency. And so this third article that I've written and we're discussing today is, okay, you've been gaslighted, now what? And in the midst of all this, I recognized that a number of years ago, I had a huge surgery on myself personally, and I had been gaslighted by my peer physician, who was head of orthopedics at the time at the institution that I had trained at and worked. And so as I wrote this, some of it became autobiographical in a sense that the recognition and realization was there that I personally, as a physician, knowledgeable, organized, had been disregarded, and it was hurtful.
So, in your own personal story, what exactly happened to you, and how did your peer gaslight you?
It's somewhat of an interesting story. I had a very large spinal surgery and was placed into, at that time, a body cast, Kydex. And I continued to have a great deal of pain postoperatively. I have a very high pain threshold, which physicians will make and have some implicit bias about sometimes when patients come in and are complaining. But I continued to assert that something was wrong, and it wasn't until 3 months postoperatively that an x-ray showed that a pedicle screw had actually been severed. It fatigued and broke. And so the interior hardware that was applied to my spine had all kind of disaggregated, and the spinal fusion was failing. We had to wait another 3 months to see whether or not that was going to solidify, and it didn't, and I was reoperated on again at 6 months and ended up spending a year in a body cast. So the pain that I had explained being present was disregarded. I felt dismissed, and it became a source of gaslighting, basically.
Now, before we talk about what patients should do if they find themselves in this position, just from your experience in this, what are some of the major reasons why physicians gaslight patients inadvertently or not?
Yeah, I think the majority, and I'm glad you said inadvertently or not, the majority really, it's not about intent, it's really about impact. So that physicians typically want to get on with a patient's story. And as I mentioned earlier, patients come in, they're disorganized, they haven't prioritized their signs and symptoms, and physicians use heuristics to begin to identify and classify and diagnose. So early interruption is not uncommon, and it prevents patients from really telling their story. So I think that when a patient becomes interrupted very early, some studies show between 11 and 18 seconds, that they need to take the time and say, I'll get back to that, but I want to finish this thought first. So it's a way of respectfully really telling your physician that you have a story to tell, they need to listen. On the physician side, let someone spin out their story for the first minute, and then you can help guide them or co-create their story by helping to organize. One of the tricks that I have used as a patient starts going kind of wandering with their story is to help them organize. So you can interrupt them and say, let me make sure that I have this correct. And you could repeat what that story is. And then you can also say, well, you've told me this already. Let me see if we can move further from this to help organize what your signs and symptoms may mean.
So it sounds like from the patient perspective, there are things that they could do both before and after they are gaslit. And I want to talk about those individually, okay? So how about those patients who felt that they've been gaslit? What are some specific techniques that they can do to make sure that they've been heard?
First of all, what we're striving for in the end is understanding the communication breakdown, what happened. Patients need to feel that their voice has been heard and that they know what's been ruled out, what's been not ruled out. So this idea of uncertainty, which we as physicians are constantly working with, has to be explained. So when you feel you've been gaslighted, when you return, talk to your physician and your clinician, whether it's a PA or your other types of healthcare professionals, and tell them, listen, I'm not sure that I understood exactly what you had advised. Here are the issues that I understand I have said to you, but I need to have an explanation for what have you ruled out, what remains uncertain, what are the things that we can do moving forward, tests, referrals, things of that nature to help us exclude the things that I think that are necessary for my signs and symptoms.
So typically, what are some spectrum of responses that you've heard, stories or case studies that you've heard after a patient has done that, kind of circle back and ask for, I guess, more clarification from the clinician? What are some typical reactions and perhaps some success stories or not that you've heard after a patient does that?
When a physician sees that the patient really is seeking partnership and communication, they're going to be receptive. Of course, with the burden of documentation, the administrative issues, the treadmill time constraints, these are all things that I think are stressing the system and stressing our physicians in trying to treat their patients the way they would like to. This is the moral injury that I referenced in a prior article, that physicians really want to do what's best for their patients. And because they're not able to, they leave dissatisfied, things of this nature.
You mentioned earlier that there are things that patients can do before, because one of the root causes you mentioned for gaslighting is sometimes a lack of organization that a patient comes to their clinician with. So what are some things that patients could do before the visit to help prevent being gaslit during the visit?
Preparation, I believe, is key. And so for those of us who have anxiety going in to see our doctor, be prepared. Write down what are the one, two, or three main things that are bothering you that you're seeing your physician for, realizing that you have a 15-minute time limit typically, and 5 minutes of that time is going to be used with computer documentation. Write down what the aspects of when this started, What makes it better? What makes it go away? Are there things that you have changed in your life that perhaps are related to these signs and symptoms? What have you done to try to alleviate these things yourself? What are the medications that you're taking? Have you changed any medications? Have you changed the schedule of medications? All of these things help you become organized and prepared. A prepared patient is what physicians really want. If you come in and say, these are the top two things that are bothering me today, this is when it started, these are the things that make it worse, these are the things that I've tried, these I've made no changes in my medications, no changes in my activity levels. Physician has a good picture of what are your signs and symptoms and can begin to apply the heuristics that are typically done by physicians to come to a diagnosis. A prepared patient is going to end up with a better clinical outcome and is going to be safer by being able to tell his or her story accurately and completely.
And as a primary care physician, I definitely concur with what you say. I am one of those physicians who have to see patients every 15 minutes. And if a patient comes to me with a printout or a list of specific questions that they want me to answer during that visit, it becomes a much more productive visit. And I've even had patients come with AI printouts of their symptoms, ChatGPT or Gemini, where they would just throw in everything that they'll be concerned about, and then the AI large language model would prioritize that with specific questions that they could bring in to see their physician. Is there a role for these consumer AI models to help patients organize their thoughts and organize their medical history before coming in to see their clinician?
I think they can be helpful, but they also kind of supercharge the visit in the sense that there's a lot of disinformation and misinformation that's promulgated by these large language models. So I think it's difficult for a patient to sort what's true, what's not true. I think as a physician, it's important to guide them and explain based upon your own personal knowledge and experience why something perhaps is not a consideration. Again, I think actively by letting patients know what's been ruled in, what's been ruled out, it's very important for patients to hear. Reassurance, one of the points that I like to make when I speak to audiences, is that reassurance given too early is not very helpful. If you come in and all the blood tests apparently are normal, the diagnostic imaging is normal, the patient, and you tell everything looks fine, the patient goes away not happy because they don't know exactly what feeling fine is. Does that mean the doctor really has dismissed me because nothing is wrong, but yet I still have these symptoms? So what is the explanation? So reassurance without explanation, I think, is a very important thing for physicians to realize and patients to understand and to be able to ask, okay, these tests are normal, what do we do next? And to confirm, based upon what you said, nothing serious is there, but what else can be considered? And if you're not comfortable in having that conversation, there is a letter format that I've included in that article. That's a sample of what you can send to your doctor saying, using the sandwich technique that I like, which is, thank you for your care to date. I understand that we have spoken about thus and such, and that that you feel that such and such is my problem. I'd like to understand what other considerations we might discuss and what is our path forward. And then close with, I appreciate your response. Again, thank you for your care. I think that a respectful recognition of the doctor trying to do his or her best is very important, and that the patients who are not comfortable having that conversation can send this in advance, either using the portal or just sending it via snail mail or email.
As a physician, what would you do in that situation? Because there are a lot of symptoms where sometimes physicians don't know what could be causing it, and there would be a slew of normal lab results and x-rays, and most of the major things would already have been ruled out, yet the patient still has these symptoms. So tell me how you would validate these symptoms and concerns, even with all your testing being negative and not having a clear answer from your perspective as to be what's causing that patient's symptoms?
Given that we work in uncertainty often as physicians, it's important to recognize that uncertainty and acknowledge that you have that uncertainty and these are the reasons why. So you're not telling a patient that you're not experiencing what they've experienced, but you're telling a patient that you don't have an explanation currently. There are ways to do this in which a patient will be accepting and understanding that there is not always an immediate answer for their problems, but you have to let patients know that you will continue to work with them to try to identify what the symptoms are, but do not acknowledge that the symptoms are real. Because when patients leave the office, leave the exam room, and feel that they have been dismissed, this really is a communication breakdown and has significant impact on the patient.
We're talking to Alan Feren, otolaryngologist and patient advocate. Today's Kevin MD article is How to Handle Medical Gaslighting. Alan, as always, let's end with take-home messages they want to leave with the Kevin MD audience.
On the patient side, it's important that your agency, that your voice be heard. When you don't understand something, ask, and ask until you understand. On the clinician side, listen for the first minute. Don't interrupt, but when you do, do it respectfully and say, let me get this right. This is what I've heard. And from there, you can help guide the conversation. You are co-creating together that history with the patient so that you can confirm a diagnosis and also firm up a partnership. I think partnership is really what I have been pushing for and advocating for years. Without that partnership, I think care breaks down. And when patients feel that their voice is heard and physicians feel that patients are prepared and working with them, they're going to get the best result in clinical outcome.
Alan, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thank you, Kevin.